Good evening, everybody. Welcome again to our session on Moya-Moya bypass surgery. This is our weekly cerebrovascular and skull-based surgery symposium every Thursday at 5 p.m. It is our sixth session of a series. I'm Vajkoczy, professor and co-chair of the Department of Neurosurgery, Director of Cerebrovascular and Skull-Based Surgery. My pleasure to have as co-directors of this course, Carolina Benjamin, my colleague, directors of our Keynes lab and specializing in brain tumor and skull-based surgery, Michael Ivan, Director of Research at the Brain Tumor Initiative, specializing in brain tumor, skull-based and epilepsy surgery, and my two endovascular and open vascular colleagues, Bobby Stark and Eric Peterson from our endovascular group. We, of course, are in Miami, Florida. Those of you who have had the pleasure to visit Miami, you recognize this iconic picture at the top left. We are a tertiary referral center regionally, nationally, Latin America, and internationally for not just cerebrovascular and skull-based diseases, but all of the neurosurgical spectrum. We've started this program on May 21. This is, you can see the sessions that have already been given. We are here, and you can see the sessions that are planned and confirmed well into September, and more are in the works for the month to follow. A teaser for next week. Next week, we're going to talk about acoustic neuromas, kind of a debate format. Conservative versus aggressive approach, John Golfinos and Marcos Tatajiba. So please join us if you are interested in that field. Every Wednesday, my colleague Michael Ivan has been also doing a fantastic brain tumor symposium, and we're up to, I think, 8 or 9 of those. And they've been very fantastic and successful, and I encourage you to join us next week for a marvelous speaker, good friend of mine, Dr. Ribas, who will talk about anatomy-guided microneurosurgery for intrinsic cerebral lesions. That's next Wednesday at 5 p.m. I'd like to thank the team that makes this happen. You can see their names: Ingrid, Roberto, Cristina, and Ignacio Escalona, who is running this webinar. If you're interested in more educational things our department can provide to you, this is the link you'll be interested in the yellow box. This is how you registered for today's symposium. There are many offerings you can see. You can review recorded tapes of what we've done today and all the previous sessions that you may have missed. You can contact Ingrid at the email you see. You can contact me by email or my Twitter account or the departmental Instagram and Twitter account. Some housekeeping instructions. Audience members, I know you will have questions, so please write them in the Q&A box. We will address them after all the speakers and panelists have spoken. And this is probably the most interesting part as well of the whole evening, is to answer your questions and get an ad-lib debate between the various people on the panel. We are not offering CMEs. Please tell your friends if you think what you're watching is worthwhile. To our two speakers, I will give them a 2-minute warning before the 25 minutes, just to keep us on time. Now, let me introduce today's panelist. I'll start with Peter Vajkoczy, professor and chair of neurosurgery at Charité University in Berlin, Germany. Peter is world authority in cerebrovascular and other disciplines, but particularly in Moya-Moya. And it is a delight for me that he's willing to stay up late in the evening, he's 6 hours ahead of us, to participate in this. Thank you, Peter, for joining. Next is David Langer, wonderful friend of mine for many years, although now he's becoming so famous. If you haven't watched it, the Netflix series Lenox Hill is really a reality show about the life of two neurosurgeons, David and his partner, Dr. Bukvar. It gives a wonderful glimpse into neurosurgery, but that's not why he's here. He's here because he is a world authority on cerebrovascular and bypass surgery, and he's a wonderful friend of mine for many years. Thank you, David. He's at Lenox Hill, the chair and professor there in New York. Third is Gustavo Pradilla, who's assistant professor at Emory. Gustavo, many moons ago, was my fellow, one of my best fellows ever. And Gustavo is doing a spectacular job in skull base and cerebrovascular surgery at Emory Clinic. And again, it's a delight that he's with us. Last but not least is Matteo Baccanelli, all the way from Buenos Aires. He's associate professor of neurosurgery with a tremendous interest in cerebrovascular and skull base surgery. And thank you, Matteo, for joining us from the Hospital Italiano de Buenos Aires. Now, on to our first speaker of the day, Gary Steinberg. Gary is Bernard and Ronnie Lacroute William Randolph Hearst Professor of Neurosurgery and the Neurosciences, Chair of the Department of Neurosurgery. He tells me until this coming September, he's partially relieved to let go after many, many years of being at the helm of this iconic department and iconic institution. He's founder and co-director of Stanford Stroke Center at Stanford. He was born in Brooklyn, undergrad at Yale. I did not know the third bit till recently. He did classic trumpet studies in Montreux in Switzerland, got his MD, PhD, and residency at Stanford. He's been chair since 1995. When he got into that department, there were 5 faculty. Today, there are 60 faculty and scientists in his departments. His contributions to the field of cerebrovascular surgery, stem cell transplantation are just too numerous to even begin to summarize here. But of course, he's also widely known for his probably the largest experience in Moya-Moya surgery, at least in the United States. He has had continuous NIH funding since 1987. And I just relish seeing how popular he was as a high school student. You can see him very well surrounded here. He's going to have to tell us his secret later. And I love that picture, Gary, bottom right, very messianic type of look ahead of what was to become a spectacular career. Second, is my immense pleasure to welcome Bin Shu, who is awake that early in Shanghai, China, just to be with us. He's professor of neurosurgery at the Huashan Hospital, Fudan University. Ben had his MD and PhD at Fudan University in 2001, residency at Huashan Hospital, did research in anesthesiology and neurosurgery at UCSF in 2003. He also did interventional neuroradiology with Jacques Moret in Paris in 2007. He was visitor in Helsinki with Juha Ernesniemi in 2010. Now, the next 2 items, those of you who don't know, although I doubt any of you listening don't know him, those are incredible numbers. He is clearly the world leader in surgical volume for Moya-Moya disease. He has performed 1,300 open surgical cases, of which more than 1,000 were in Moya-Moya. Gary, please mute your phone if you don't mind, 1 second. He's done 150 endovascular cases in 1 year, 7,000 cases of Moya-Moya, over 100 hospitals, clearly very different practice pattern than most of us in the US have had. So that is, I would say, that qualifies him to be an expert on Moya-Moya disease. And he's a very good friend of mine. And most importantly, he is my supplier of excellent Chinese tea. Every time we meet, he gives me a selection of the best tea that one can have. So thank you, Ben, for joining us at this hour. So now I will stop and I will invite Gary to share his slides and begin his talk. Unmute yourself, Gary.
How's that?
Perfect. We hear you now. Thank you.
Great. So Jacques, thank you so much for inviting me. I think this lecture series that you guys have put together is a wonderful idea in this time of COVID chaos in terms of continuing our educational opportunities. And I think it's shown us also that we can continue to do this kind of education in the future virtually. We've all become very proficient with Zoom. I don't know where you got those ancient pictures of me, but you're a real sleuth, but it does remind me a little of the time we were in Brazil together.
Yes.
So my charge is to talk about bypass for Moyamoya, justification, timing, and complication avoidance. And you can see, I just want to put into perspective, let me move these people out of the way here. We have treated now over 1,200 patients, done 1,870 bypasses in patients from all over the world, predominantly the US, of course. And although it was first described, and many people still think it's a disease only of Asians, that's clearly not true. In our practice, half of the patients are Caucasian, but every ethnic group is really represented. And as with many cerebrovascular diseases, 3/4 of the patients are female. You can see here, I do prefer to do direct bypasses, and I'll explain why a little later in the talk. 3/4 of the patients that I treat are adults. And unlike the distribution in terms of age in Japan and Asia, we don't have a bimodal pattern, at least not at Stanford. Every age group is represented, although the 30 to 49 age group is the most prominent, but we've treated patients from 7 months to 74 years old. Why should we be treating these patients? What's the natural history? I think that while there's not been a randomized prospective study comparing bypass to medical treatment for ischemic Moyamoya disease, that recently was done for hemorrhagic Moya disease. A landmark paper from Japan a few years ago showed that surgery bypass is better than the natural history. And all of us believe now, I think, that this is a disease which inevitably progresses with variable course. 2/3 of the patients progress over 5 years, and multiple studies have shown the 5-year stroke rate is somewhere between 15 and 75% with surgical treatment. In this meta-analysis by Fung and almost a 5-year follow-up, there was only a 2.7% progression rate. Now, I get sent a lot of patients who are thought to have Moyamoya, but many of them don't. And this is an example, a 72-year-old who's symptomatic, but this is atherosclerotic arterial disease, not Moyamoya, and we don't treat patients like that, even though there is sometimes a Moyamoya type of pattern of the lenticular striate arteries. So let me move this out of the way here. So what we've done is to look at preoperative risk factors, and out of our 1,250 bypasses in 769 patients between this period of time, we analyzed various risk factors, including the modified components of Peter's very nice Berlin grading scale. And that very importantly includes the DSA score in terms of the degree of stenosis occlusion and the collateralization, the MR brain score, whether there's symptoms or signs of prior strokes, and more importantly, whether there's a positive DWI at the time of surgery, and a hemodynamic reserve score factor after acetazolamide in terms of impaired augmentation or steal. Out of all those factors, we found 4 were highly correlated with post-op bypass of stroke in a multivariate analysis. That was age, DSA score, MR score, and hemodynamic reserve score. And not surprisingly, age was a very powerful determinant of the 30-day major postoperative stroke rate. So you can see patients under 18, less than 2% stroke rate, between 19 and 39 years old, less than a 5%, but as the patients gain more maturity, 11% in this age group, and over 60, I don't like to bypass patients in general because there's a 15% stroke rate, at least in our series, for a total stroke rate of about 4% per procedure. Many of these patients actually did recover within 6 months, but I get upset every time we have a stroke. Most of these are ischemic. We rarely have now a hemorrhagic stroke problem post-bypass. We looked at some patients that, and this was a retrospective study, we had 6 patients who had large strokes post-operatively and compared those with 25 patients who did not have strokes. And we found a significant difference actually in this group. So the patients who had poor outcomes, 83% of them at the time of surgery or within the week before had DWI positive infarcts. And it might have been only something as small as a little tiny punctate lesion like this. And none of the patients who had a untoward course had any of those new strokes. Also, we found that those patients who had the large lobar strokes postoperatively had impaired augmentation in the anterior circulation, often with steal phenomena after giving Diamox. Here's an example of a 43-year-old patient, bilateral moya-moya, and you can see after Diamox, she has impaired reserve and even steal phenomena in these areas. Here's a preoperative study. All she had was a punctate, tiny little new lesion. You wouldn't have thought that would have mattered. And here's what happened post-operatively. Sometimes in a few of the patients, the new postoperative infarct was not even in the same hemisphere, but that is a risk factor indicating instability, and both the preoperative acute infarcts as well as impaired reserve were independent risk factors for large infarcts. So I delay surgery if the patients have a DWI positive infarct a few days before surgery. I always do an MR right before I do the bypass, and I will delay it usually for at least 2 weeks, often for a month if they're local and not from out of state. I wanted to show you how we troubleshoot some of the problems, and this is an example. This is actually an occipital artery donor, which is more difficult than the superficial temporal artery, but here's an artery. We cut it getting ready for bypass, and there was no flow. So first you flush with heparinized saline and then papaverine, still no flow. Sometimes there's a little clot in the artery. Then I will pass a wire retrograde. This is a pediatric 3 French catheter wire. And then you can determine the site of occlusion. And here what we had to do was actually cut the artery, open it up, restore flow. Sometimes you can have an occlusion if you coagulate too close to the artery, but that's a good trick. During the bypass, there are several things that I do which I think are important. Normal capnia, do not hyperventilate the patients. We keep the MAP high, in the high normal range for that patient. I used to monitor SCPs and MEPs. I don't do that anymore because we never saw a change in the operating room. If patients do have a problem, it's post-operatively in the ICU, and it's not even usually immediately. It's usually within 12 to 24 hours. And we found that it costs between $10,000 and $30,000 extra for the monitoring. Propofol for burst suppression. I always do ICG angiography. In addition, I'd like to measure blood flow before and after surgery in the M4 branch, pre and post, as well as in the STA with this transonics flow meter that Fatty Charbel developed, which is both quantitative and directional. I wanted to show you how we use the flow meter. This is the M4 branch. And here's the flow meter. So we measure flow and see which directions it's in. I like to fish mouth the artery because I think that makes the bypass easier and increases the patency. We developed some special clips with LASIK company that are lower profile. And then I'd like to snip off a piece of the STA. We're studying this with RNA and protein analysis to look at changes. And I learned to stain the artery, actually from Hiro Hoken in Japan many, many years ago. And always put the toe in first and then the heel end in so you can adjust that. And then at the end of the procedure, you can see how we measure flow again in the proximal segment of the of the M4 and in the distal segment and in the STA, and I'll show you some data. Now we've learned quite a bit about these the flows in these brains from looking at the ICG. So here's an example of a patient before bypass, the M4 branch. Maximal flow was very low. Normal is 10 to 20 mLs per minute in a non-moya-moya. Look at this to and fro flow pre-bypass. Very impaired flow. Almost zero, actually. And you can see that on the color image. And then post-bypass, nice bypass. And now you can see we have proximally 12 mLs per minute going proximal, which is what you want because it travels proximal down to the occluded area and then out distally to sometimes apply the whole MCA distribution, and distally 37. So you can see how much flow we can get total in the MCA. SCA graphs often could supply quite a bit of blood flow. It's not always a very low flow graph. And you see, this is a study we published. We basically increased flow about 5 times on average. Total flow in the MCA post-bypass. We looked at some of our complications in the small number of patients who have hemorrhage. You can see a statistically significant increase in the post-bypass flow in the operating room, not surprising. What was surprising to us was that the ischemic stroke patients also had a statistically significant increased flow in the bypass, post-bypass compared with the controls. We think that's due to competing flows. So we keep the pressure actually higher post-bypass. One other thing I learned in terms of decreasing complications is the occlusion time. When we started doing this, my occlusion times were 25 to 50 minutes with some outliers. That was the first decade. In this period of time, we decreased it to about 16 to 35 minutes. Now our occlusion times are pretty routinely 11 to 22 minutes. We had a record this year of 8.5 minutes. That includes having the fellows and chief residents put a stitch in. I know many of you have seen this transient neurologic deficit. It's an interesting phenomena. The patients wake up okay, then within 6 hours to several days, and sometimes it's days later, they develop neurologic deficits, usually in the left hemisphere. It's often speech problems, language problems. Sometimes it involves problems moving the tongue or swallowing. It's really an apraxia of the pharyngeal and bulbar musculature. No MR edema, no stroke, EEG negative, and then it resolves. We don't know what it is. Is it hyperperfusion, hypoperfusion? And that makes a big difference of how you treat the patient. No correlation with any of these factors. It's more common in adults, a trend to be more common in the direct bypass patients, and a trend for worse preoperative MR score. So we did a study after looking at the Japanese literature. Now the Japanese felt, based on PET imaging and SPECT imaging, that this was due to hyperperfusion, and therefore they are aggressively lowering the blood pressure. And we found with our flows at surgery, there was initially at the time of surgery a statistically significant increased flow in those with TND. But some data suggested there was not a problem with too much flow, but hypoperfusion. This 40-year-old cardiologist had a stroke. You can see here had recovered completely, although had initially some right visual loss. And you see he was fine for 2 days, then developed some expressive aphasia that resolved. And you can see on his xenon CT, this is pre-op. And post-op on day 6, when he was symptomatic, he actually had lower flow compared with pre-op, and impaired reserve compared with what he had pre-op, which was even worse at day 9. And so we thought this suggested hypoperfusion. So we did a study with a flow meter that was placed into the cortex. We had IRB approval to do this. And with this flow probe, what we found, interestingly, here's the patients who developed the transient deficits in the left hemisphere. We compared it with patients who did not develop in the left hemisphere and those in the right hemisphere. And very interestingly, while the transient neurologic deficit group, the flows started higher, they had no deficit at this time. They had more variable flow compared to the control groups. And then when they developed the deficit, the flow actually dropped. And so it reflected hypoperfusion. And when they recovered neurologically, their flow improved. So we believe very strongly this is due to local hypoperfusion. And we keep the pressure actually higher than normal for a period of time. Often we'll keep it high for several weeks after surgery. And we have found that that has decreased our TNE rate. Now, several unresolved questions. A number of groups, including Sandra Conley's group, the group at UCLA, and Chris Ogilvy's group have been doing indirect bypasses, and their publications suggest that they do achieve good results without increased complications. These patients generally are in the young adult group, and I wondered whether we could do indirect grafts because it's obviously easier to do that. The advantages of the direct bypass over the indirect, and many people feel this way, are the immediate increase in blood flow, better angiographic revascularization, improved hemodynamic reserve compared with indirect, better long-term clinical outcomes in many studies, lower rates of repeat revascularization. The disadvantages are that it's technically more demanding. Very few pediatric neurosurgeons actually do this procedure, but I think that it's really not a problem with experience. And some people feel there's a higher perioperative risk of delayed transient deficits. No randomized trials. We don't know which is better for cognitive outcome. Here's a patient I treated who had a hemorrhage, and the referring neurosurgeon took a clot out, so I couldn't use the STA. I did an indirect bypass, EDMS. You can see good revascularization, but it never looks as good as what you get with a direct bypass. By the way, a direct bypass, if you lay the artery on the surface of the brain, you always get an indirect also. And so other people have shown in a meta-analysis that direct bypass is better than indirect, both acutely, except for a very slight increase in the perioperative hemorrhage rate. Long-term outcome, it's better. And in the patients that we have repeat revascularized, these are mostly patients referred from outside, 70 of them, but we had 70 who had initial surgery at Stanford that we had to repeat the revascularization because an area was not well revascularized and they still had symptoms. We had a 4% need for revascularization in the indirect group and only a 1% in the direct. So direct is better in this respect, at least with our Stanford patients. So we decided to do a study at Stanford individualizing the use of direct versus indirect based on the degree of stenosis or occlusion, the cerebrovascular reserve, the severity of clinical symptoms, and measuring flow in the operating room. Patients with mild to moderate stenosis of the ICA or M1, if they had preserved reserve, if the M4 flow was greater than or equal to 8, which is just below normal, if they had in an anterograde direction, and they had absence of frequent and severe TIAs or stroke where we thought they needed immediate blood flow, they were assigned to the indirect bypass group. We treated 138 patients with 195 hemispheres over this period of time. We just published this 2 weeks ago, and there were 133 direct bypasses, 62 indirect. And we looked at the 7-day major stroke rate with a new deficit, DWI positive, that still had a decline in the MRS at 6 months. and found no difference in the 7-day major stroke rate. And in fact, the DSA revascularization at 6 months was better in the direct group. We haven't looked at the long-term clinical outcome group, but based on this, I believe direct bypass is better. And I've gone back to doing direct bypass in all of the patients, unless they're very small kids. Here's an example of something I learned early on that I don't do anymore. This was a woman who had bilateral indirect bypasses, still had bilateral TIAs, and you can see still there's some revascularization, but not very good. So I did a vein graft, saphenous vein graft on the left side. She did well, still was having right hemisphere TIAs. I came back and I did a vein graft on the right side. You can see there's a mismatch, but I thought this would work because it worked well on the other side. And so I took the clip off, and I saw very large pulsations of the brain and hyperemia, which I was not happy with. So I re-occluded the graft and gradually let the clip off over a period of about an hour, and I was satisfied with the result. She did fine, sent her home, no problems, until 10 days later, a neurosurgeon in the community called me and she had a fatal hemorrhage. I think large flow grafts, radial artery or saphenous vein are not the right procedure. I think these MOYA-MOYA patients just need a little bit of extra blood flow to get them through it, and the STA is the perfect artery for that. Here's another complication we have rarely, and I don't know what to do about this. Here's a patient who had a left frontal stroke, bilateral small watershed strokes, bilateral disease, but we treated the left side, did a bypass, and then postoperatively had a stroke on the right side and a small one in the left. And this patient went on to occlude actually what was only a moderate stenosis on the other side. Of 1,450 bypasses, we had 2.4% new symptomatic contralateral infarcts, and 8 of these patients showed progression of a contralateral stenosis. They did improve some with increasing the pressure, but at discharge, they still had worse MRS scores. At 3 years, a third of them recovered. But what I learned from this is that the two hemispheres communicate much more than we used to think in terms of their hemodynamics. And so bypassing in one hemisphere can cause significant changes in the other hemisphere. Now, what about
Gary, 2 minutes if possible.
Yeah, problems with wound breakdown. We see several patients a year. We work with the plastic surgeons, and I've changed my approach. Gentle tissue handling. Do not over-attract the skin. Don't devascularize the scalp. Extend the skin incision. And I now close with nylon and leave the suture in for 2 weeks. I used to put in resorbable gut, and in addition to antibiotic solution, vancomycin powder. What about patients with intractable headaches or cognitive deficits? Here's a quick study I'm going to conclude with. 30 patients, no MR evidence of stroke or hemorrhage at all, yet 23% before bypass already had significant cognitive impairment and 37% significant emotional distress. Can earlier revascularization prevent cognitive impairment? We don't know. We're studying that. Which patients should have revascularization? Certainly, so those are symptomatic with prior strokes, usually poor angiographic filling and impaired reserve. I also believe minimally symptomatic patients and those asymptomatic with prior strokes and impaired reserve. I think we're not operating early enough on many of these patients. I don't operate on asymptomatic patients. I don't operate, as I said, if they have acute infarcts, I delay it. Older patients I don't like to operate on. And this group I don't know about with medical comorbidity. I just want to acknowledge our team at Stanford who are responsible for our success and acknowledge the patients. It's a very gratifying disease to treat. The vast majority of patients do very well. They go on to have normal lives, get married, have families, win debating contests, participate in extreme sports, ice climbing, skydiving, trapeze acrobatics, and maybe the most high risk, becoming a physician. Thank you very much.
Thank you so much, Gary. That was fantastic. And I know you could keep going for a long time with your experience. I appreciate that wonderful summary. By the way, the listeners, in addition to the people who are with us right now here, I'd like to put a shout out to Dr. John Bennett, who actually runs a neurosurgical TV channel for many years, well before COVID. And I know many viewers today who don't appear at the bottom of this Zoom are watching us live on the YouTube channel that he has, Neurosurgery TV. Ben, please go ahead and unmute yourself and share your slides. Looking forward to your presentation.
Okay, thank you, Professor Morcos, and good morning, Peter. This is a very early morning in Shanghai. So my topic is a bypass surgery for Moyamoya disease, about learning curves, results, and the technique tips. So bypass surgery is need a lot of things: balance, coordination, speed, concentration, agility, patience, flexibility, and perfectionism. So bypass is like running on a mountain ultra trail. So how can a resident hike this mountain? So we train them use models, live models, or high flow central training. This is a model training. You can use plastic glove, silicone models, or plastic balloon, chicken wings, placenta vessels. This is a live model training. Normally we use rats for the bypass training. So you can see this is a job done by Dr. Alicia Flestiani in our hand surgery laboratory. So we should make these steps easier, and every resident can did it. So Alicia trained in our hospital for 2 months, and I showed her for more than 160 bypass in 8 weeks. So after she come back to Italy, she already did 8 STMCA bypass as a resident, and the patency rate is 100%. So last week she performed 3 bypasses. The mean occlusion time is 23 minutes. So this is the follow-up DSA for her work. So you can see the double bypass was all patent, and the STA enlarged a lot, and the blood flow come to M2. So I come from Huashan Hospital. This is we have a huge department of neurosurgery. Last year we have 18,000 operations in our department. We have 4 campuses. Our department have around 800 beds, 40 operating rooms. So normally I have two rooms. So this is my personal experience in bypass surgery. It's also my learning curve. So last year I have 1,039 cases. So my personal record is 5 minutes 40 seconds to finish a stoma, and 13 cases, bypass cases in 5 operating rooms. So until now, I have more than 7,000 bypass cases totally in China and India. So this is 10 cases. After 10 cases, we still have time to have a dinner. This is in one day, I have 15 cases of moya-moya, including 2 indirect bypass, indirect procedure. So the ECA have 3 branches, and the first layer is the STA, or post-auricular artery, or occipital artery of scalp, and then the temporal muscle, deep temporal muscle artery, and the dural middle meningeal artery. For the late stage of moya-moya, normally the middle meningeal artery already formed the spontaneous stomas with arteries of cortex, so the MMA should be kept intact. Sometimes MMA also can originate from ICA branches, especially from ophthalmic artery, like this one. You can see this middle meningeal artery come from the ophthalmic artery, but not from the ECA. So I prefer to use a combined approach of moya-moya, STA, MCA bypass, sometimes post-auricular or occipital artery to ACA or PCA territory, combined with EDMS. So this is a follow-up cases. You can see the STA, all the 3 layers of the arteries formed spontaneous stomas or direct stomas or patent. So every case was individualized, designed. So this is a skin incision, the bone flap, dural, and the targeted bypass to ischemic area. Sometimes the EDAS normally was not very effective for the adult patient. For this patient, you can see the patient already have 2 bilateral failed EDAS. So I do the double bypass of bilateral frontal branch of STA, direct combined with EDMS. So STA-MCA bypass was an end-to-side anastomose. Most adopt blood flow augmentation procedure. The indications include moya-moya disease, complicated aneurysms, MCA occlusion or ICA occlusion. So for this, especially in moya-moya disease, already existed ischemic condition. So time is very important. The mean temporal occlusion time, just as Professor Steinberg showed in his slides, the shortest one he take is around 8 minutes. That's a very fast. But in COS trial, the mean temporal occlusion time is more than 50 minutes, and normally 20 minutes in a very skillful bypass neurosurgeon. And I prefer to use so-called the simplest anastomosing technique for a trained beginner. It's only take 20 to 30 minutes, just like Alicia's speed. My personal record is 5 minutes and 40 seconds. So in my personal series, the mean occlusion time is 13.5 minutes. So the STA is different in male and female. Actually, this patient is a post-auricular artery. This is the STA. Normally, the male patient, the STA is thicker than the females. So dissecting of the STA mean time in female is around 7 minutes. They have less big branches. STA diameter is around 1 millimeter. In the male patient, normally it takes more time because they have more bigger branches, and the STA diameter is 1.2 millimeter. So this is harvesting the STA, I always dissect the STA from inner side of the scalp, use a low power monopolar. So this is a very fast procedure. And close the incision of superficial temporal fissure from inner side of the scalp after harvesting the STA. Sometimes even close the 2 layers, including galley and the superficial temporal fissure. If the suckles is wide, I will fix it with a dural strip. So after this treatment, the delayed scalp healing or infection of the scalp never happened. So the mean thickness of a female scalp is 6.5 millimeter, and the mean thickness of the male scalp is 7.8 millimeter. So the incidence of the delayed scalp healing or infection is higher in female patient. So when we do the craniotomy, keeps the integrity of STA, deep temporal artery, and the middle meningeal artery network. So craniotomy, this kind of patient is very sensitive for bleeding. So the bleeding was controlled very strictly. Sometimes for the late stage, already have some spontaneous stoma come from middle meningeal artery, I will use a divided bone flap to keep the middle meningeal artery intact. So the best protection of a middle meningeal artery is keeping the integrity of middle meningeal artery, middle meningeal vein, and the covered bone complex, like this way. So this is under the microscope, we can see the middle meningeal artery and the MMV. You can see there's some hole in the middle meningeal vein. So this is impossible to coagulate at the same time to keep the patency of the middle meningeal artery. So I use this technique. I use a strip of gel foam to cover the middle meningeal, the holes of the middle MMV, and like a Chinese spring roll to keep the integrity of the middle meningeal artery networks. At the meantime, to keep the blood of the MMV. So after the second successful bypass, after the first successful bypass, the second one can be used for hands-on training. Like this patient, this is my work, this is my trainees' work. So this is a double bypass of STA-MCA. So you can see the double bypass with all patent. So the residents' first 10 bypasses performed by assistant were all trained in this way. The stoma is located in ischemic area, but not at the infected area. So this is my assistant, Dr. Anqing Zhu, and this is his learning curve. You can see at the first year, he got 80 cases, and this is a case number, 10 cases, sorry. This is a patent rate, and this is a complication rate, yellow line, and the mean occlusion time. This is a red line, is a mean occlusion time. So at the first year, he was trained for 10 cases, and the mean occlusion time is 43 minutes, and the patency is 80%. This is my another assistant, Dr. Gao Chao. And the first year, he has 54 cases, and last year he had already have 136 cases. So you can see the mean occlusion time was decreased. From the beginning, it's around 40 minutes. Now it's around 20 minutes. Another assistant, Dr. Liao Yujing, and now you can see the temporal occlusion time is also around 24 minutes. Another assistant, Dr. Xu Feng, and this is his number and the temporal occlusion time. Last year, he go to another province for support to the local hospital, so he has no cases in last year. So the simplest technique in anastomose, I only use 2 or 3 curved micro temporal clips. Don't need to sacrifice any branches of the recipient artery. And I never use a rubber mat or silicone rubber tube. Only take the interrupted suturing. Square knot is enough. You can see this is a square knot. It couldn't be loosened. And this is a slice knot. You can see if the suture tail point to the same direction, actually the knot was not, it's like this, it's a slide knot. So we should analyze the different topographic feature on the, this is the first type on the surface of the brain. You can handle the recipient artery very easily. And this is on the slope of the belly. We can occlude the recipient artery in an oblique way. And this is in the belly. We can elevate the recipient artery a little bit, use temporal clips to make the anastomose easier. Sometimes I let a small branch open to slow reflux of the blood flow. This can keep the recipient artery's vessel wall a little bit open and make the procedure easier. So I want to introduce 2 common fluid mechanical principles. The first one is a Poiseuille law. So this is a Poiseuille law. So delta P is the only motive power for driving the blood flow. So we should make sure to keep the delta P positive. The stoma near the higher pressure location is dangerous for delayed occlusion of the bypass. So we should select the right position of recipient artery. So this is the first pressure gradients of MCA. It still keeps the physiological direction from the proximal part to distal part. But sometimes there's the second type gradients of the MCA. You can see this is a PCA. Then the M2 was the latest time. So this for this reversed physiological direction, the P proximal was less than P distal. So this is a higher pressure zone. This is a low pressure zone. So after a successful bypass in the flow 800, we can see a red T sign like this. This is a red T. This is the double bypass, 2 red T. So bidirection faster blood flow means big difference of delta P. So this kind of bypass is sustainable. But sometimes if the red T, one arm is short, actually this means delta P is very positive. Like this patient, you can see that one arm of the red T was very short. It means delta P is very small. So after after 1 week, you can see the bypass was almost occluded. So this is a case from Dr. Zhang Jianjian from Wuhan. So we compared the different different way. This is the first pressure gradient of my MCA. I called this is a parallel bypass, which keeps the main blood stream of the donor artery with the recipient artery's pressure gradient the same way. So I called this parallel bypass. This is a second type. You can see this is a reversed direction. So the result shows the parallel bypass is better, which means that the main stream of the donor artery keeps the same way with the recipient artery's pressure gradient. So the second common fluid mechanical principle is the Bernoulli's principle. So this principle is mainly about blood flow energy loss. So hemodynamic change of MOYAMOYA, it's like a throat principle. You can see this is the flow velocity of the MOYAMOYA vessel is largest to the constricted section, and the increase in flow velocity is accompanied by a significant decrease in pressure at the constricted section. Actually, the M1 through the MOYAMOYA vessels to M2. So the M2, the velocity was already decreased, and the pressure was increased comparing to the MOYAMOYA vessels, but it's already decreased a lot comparing to M1. So actually the local energy loss varies with the shape of the stoma. So this is the relationship among the diameter, the perimeter, and the cross-section area of fish mouth anastomosis. So we can calculate the resistant coefficient zeta according to the fluid mechanical formula. So this is for the fish mouth stomas calculating. So the greater the ratio of A3, this is A3 to A1, is the greater the resistant zeta is, and the resistant coefficient the zeta is proportional to the square of A3 to A1. So zeta, this is a formula for zeta calculating. For the this is a good example. So we can see this is a ICA ampere part. We can see the fluid separated, and this is a additional energy loss part. So in my opinion, the stoma should keep the oval shape as a natural branch. You can see the natural branch is all oval shape like this. So this we can also calculate the zeta for the ovoid anastomosis. So this is a relationship among diameter, perimeter, and the cross-section area of the ovoid anastomosis. So this is a formula for calculating the zeta in ovoid anastomosis. So under the same condition, the ratio of A3 to A1 is closer to 1. So the zeta is smaller comparing to fish mouth, and the local energy consumption is lower than the fish mouth stoma. And this is a stitch sequence. Normally I use 12 stitches like clock points. And after the first stitch at the toe, we still got the last chance to trim the stoma to make the same size from the donor artery to the recipient artery. So this is a real-time video of anastomosing. So use two small temporal occlusion clips. 10-0 prodding suture. So you can see it's around 6 minutes. We can finish the anastomosis. So this is after removing the temporal clips. You can see all the recipient arteries, all the small branches keep intact. So sometimes I left a tiny perforator of the recipient artery open to let the small reflux of the recipient artery. So this can keep the 2 layers of the recipient artery unattached with the small pressure of the reflux flow.
Ben, if you could maybe in 2 minutes, if possible.
Okay. So actually we can use the loop technique. It can even make the procedure faster. So in the STA, we can see some sharp bends are very common. So my solution is to reduce the angle of theta, and I will cut this connective tissue and to make it more straight. Actually, according to the calculating, this the energy loss is much less than the, and because of the time, sometimes if the recipient artery have some small holes, we can make a patch, use fat tissue like this. So this is according to the hemodynamic calculating. We can use a double bypass like this, 1 single branch to create a double barrel bypass. And this is a one single bypass, double bypass, triple bypass. And this is the whole hemisphere fed by the ECA branch. So you can see the whole hemisphere was fed by the STA, even the contralateral lobe. So this is a follow-up angiogram. You can see for this is a young boy. You can see the whole brain fed by bilateral ECA. So this is a blood volume change in arteries in different branches of ECA was all increased and decreased in ICA and the basilar artery. So bypass technique is not a dying art. Ischemic brain can be revascularized. The simplest bypass technique is easy to learn by residents. Thank you. Thank you, Peter, for this fantastic book.
Thank you so much, Ben. Fantastic. Could you stop sharing your slides?
Okay.
That were very, very important technical bits, and your experience, of course, is unmatched and so forth. But we'll come to the questions later. Now, I'd like to invite Peter to share his slides. And Peter, you take it from here. You're in charge. Show us a case, challenge the speakers, whatever you'd like to do. You unmute yourself, Peter. You're muted. You're still muted. Ignacio, could you unmute him?
Good job. Sorry.
That's okay.
Now, can you hear me now? Good.
Yes.
So thank you very much for the kind invitation. I'm delighted to see how successful your series is, and it's a big honor to speak after these two heroes of MOYA-MOYA bypass revascularization. So you asked us to challenge the speakers. I'm happy to do so. I will first like to point out and advertise the book, but has been already mentioned. I think this is a very valuable contribution of different authors in the field, showing their different techniques, and it's for sure a gain for everybody who starts practicing and doing these kind of procedures. So the patient that I would like to share with you is a 37-year-old patient with repeat TIAs, minor strokes on the left hemisphere. You can see the strokes, and from Gary we have heard this would be maybe a high-risk patient, which is then confirmed in the CBF study. We like to use water PET, and we are strong believers that we should have quantitative CBF measurements. In fact, this is a xenon CT, which is a little bit of old-fashioned, or water PET. And we like to use Diamox for challenging. And on the right side, you can see the severely affected left hemisphere, suggesting the reduction in Diamox. So this is a strong statement for using these kind of algorithms for choosing the patients, as has been mentioned before. We performed a regular STA-MC bypass, and in contrast to the previous speaker, we like to do minimally invasive or targeted approaches, not necessarily targeting the area that really is malperfused, but targeting the end of the Sylvian fissure with a tick hole craniotomy. On the left side, you can see on 2015 the DSA showing the typical changes of the Moyamoya vasculopathy. This is the small craniotomy that we have performed, and we have performed an STA-MCA bypass and combined it with just flipping around the dura. In the end, it's an encephalodurosynangiosis. So this is what we regularly do, and we have standardized this procedure. It's not really individualized. We believe that the collateral blood flow is so strong and the leptomeningeal anastomosis are so well established that we prefer a mini open standardized approach, which takes 60 or 90 minutes in the end. And this bypass worked well, as you can see here, but without a good explanation. 2 years later, the bypass was occluded and the patient became symptomatic again. On the left side, very nice example of progression of the disease. And you can still see the craniotomy, but you can see that the bypass has vanished and that the indirect revascularization that is still fitting. The encephalodurosynangiosis. Jacques, you might want to unmute yourself.
Right.
So this is the new water PET, and this now really shows that occlusion of the bypass and progression of the disease shows a more affected left hemisphere now. And now this is where I'm going to be provocative. What's the best strategy to revascularize? So we like to perform the small craniotomy here. This gives us the opportunity to perform another bypass here using some kind of modified pterional approach. Our series shows an occlusion rate, delayed occlusion rate around 4%. And we like to use the other STA branch, but if this STA branch is not available, we strongly advocate using a radial artery. So this is in contrast to what Gary has mentioned, and we have made very good experience with the radial artery, using the pterional opening here, harvesting the radial artery, and then, as illustrated in our book, performing an end-to-side anastomosis to a cortical branch or to an M3. This is the intraoperative view, the intraoperative DSA, showing the radial artery from the external carotid artery, filling a distal MCA branch, and you can nicely appreciate how this bypass is filling the whole hemisphere. And we have not observed hyperperfusion, we have not observed breakthrough hemorrhages or complications. It's just working nicely for those patients that fail initial STA bypass. And this usually leads to a normalization of a very severely affected hemodynamic compromise. And this is the recent follow-up this year, showing that the bypass is still filling the whole MCA territory and is giving a very nice image, and the patient is now asymptomatic. So, and no new infarctions. So what can you learn from this case? Number one, we can observe late occlusions of good-looking STA-MCA bypasses, and we do not know the reason for this. We have continued antiplatelet therapy for this patient. We see that these indirect bypasses have a very low take rate in adult patients. We have shown it's less than 50%, and if there are vessels, the contribution is minor. We have shown that radial artery grafts, we now have a series of about 15, are useful and safe. the technical aspects of our revision strategy have been shown in case that there is no second STA available. We see a regression of indirect techniques in light of a good bypass. So the post-operative angiogram has shown that the indirect vessels have vanished. So did the MOYA-MOYA vessels. And it's a very good approach for secondary stroke prevention and also improves neurocognition, as has been recently also been discussed on Twitter by Amir. Very good cases. Thank you so much, Chuck, for having me on the panel.
Thanks, Peter. Can I ask maybe Gary and Ben to kind of address some of those points? What are your comments on maybe number one is any hint why do excellent direct bypasses occlude slowly over time? We've all seen it. Gary?
Yeah, you know, we do angiograms on all of our post-bypass patients at 6 months, 3 years, 10 years, and 20 years. And what we note is that some of the direct bypasses, they actually become very much indirect bypasses, even in adults over time. Fatty Charbel and Seppi at University of Illinois, Chicago, published a paper regarding this. So even if you have a really good bypass, if you harvest enough artery that you lay it on the surface, you will get indirects, especially in young adult patients. You'll get indirects too. And sometimes, you know, it converts more to that, but the patients do fine. I don't know why we see late occlusions in the bypasses. You know, it may be that patients develop, you know, their own collaterals, and that the bypass was necessary to get them over the hurdle when they were ischemic or not.
Yeah, Gary, have you? I put together my series and I tried to replicate Fadi's data of cut flow index being a predictive.
Yeah.
Of, I could not replicate it.
No, I don't think it pertains to MOYA-MOYA. I think it pertains to acute occlusions for like an aneurysm when you acutely. I don't think it is relevant at all for MOYA-MOYA, which is a different process.
I agree with you. I got the same thing.
Yeah.
Ben, can you comment on some of the points Peter has brought up?
Peter, this patient have occipital lobe infected.
True.
Yeah, left side, yes.
Yeah, it was
so actually, I think for this patient, for this patient, I think a more posterior location of the recipient artery would be better choice than the regular one in the distal part of the MCA. So more posterior to the occipital artery.
It was the temporal artery, leaving the Sylvian fissure at the end.
No. I mean, I will for this patient, I will use a combined approach. The EDMS, maybe double bypass, one in the frontal one in the regular location, the second one in the more posterior for the occipital lobe. And I think there's this kind of patient have some different competition between the different layers of middle meningeal artery, deep temporal artery, and the STA. So for this patient, I noticed that there's already some spontaneous stoma come from the MMA. So this may be decrease delta P of the donor artery with the recipient artery. So in my series, I also noticed some around 1% of the recipient artery, the STA MCA was occluded because the delayed spontaneous stoma come from middle meningeal artery and the deep temporal artery. So because the indirect stomas actually delivered the blood flow more efficiently than the STA. So this can cause STA occlusion.
Yeah, but to continue the discussion, number one, the preoperative PET scan showed that the whole hemisphere was affected, despite the occipital lobe smaller infarction, but it was an ischemic compromise or hemodynamic compromise of the whole hemisphere. So I think it's a good example that you cannot really rely on the MR, but have to rely on the quantitative CBF study. And number two is that the bypass occluded after 2 years. The indirect, you say, has taken over, but the brain was even more ischemic or more compromised than before. So my conclusion is that the indirect had really no use and was not the cause of the bypass occlusion.
I think that one of the things I've seen is what I would call collateral shift, where if all the vessels communicate, you can actually see, I've seen collateral shift from a right side of bypass shift where you'll see ACA flow that used to isolate to one side. All of a sudden you'll see it through the ACOM shift to the other side. That I don't think, as long as you don't have compartmentalization of your ischemia, I don't think it's as important of where the graft is the best recipient and the best donor is what's important. Once you have, the trouble with MOYA is sometimes there's just compartmentalization when you get an occlusion of the MCA bifurcation. And then you've isolated, portions of the middle cerebral distribution, just like you might get isolation of the PCA in an occipital infarct. That's, then you're talking about pedal collateral through an MCA graft, different problem. But I do think I've seen remarkable collateral shift where as long as the MCA bifurcation is open, we all are taught to bypass on the frontal side, which I almost always do. But bottom line is, if you don't have compartmentalization in the brain, I kind of agree with Peter. I'm not so sure it's as important of where you put the graft. I mean, Ben, obviously you have a huge experience, but perhaps it's about the compartmentalization, the different way these people are presenting rather than, where the actual stroke resides. It's a question as much as a comment.
Peter, was there an occipital artery available as a donor?
Going back. No.
Because that's what I prefer to. I would use that as my first option. If you can go to the posterior parietal region, but if that's not available, I think your solution is a nice one, actually.
Yeah, the occipital goes all the way to the angular artery. I've done a few of these, but not much further than that.
Right.
I feel that David's point is very important because it brings us down to whether we should target the bypass or whether we should do a standardized way, trusting that the leptomeningeal collaterals work fine. I think the only situation where it doesn't work so well is if you have an A1 occlusion, then obviously we should not go maybe to the MCA territory, but in all the other ways, I think that David's point is valid.
Yeah, I mean, so it's interesting conversation of direct versus like throw everything at it versus direct. I must say, I do like you, Peter, I do like a straight incision. I don't add combined. And I remember, Peter, once, I think we met in the Middle East, you were giving a talk and you presented data showing the contribution of the combined portion of the indirect portion of the combined was very little compared to the direct flow contribution. And I asked you at the time, why do you still do combined in the indirect portion on top of the direct? You said, like, as a insurance policy. Do you know what I mean? Do you still feel that that's important, or you've changed your views about that?
The data that you referenced was a Mannheim data led by Peter Schmiedek, and there we have compared direct STA-MCA versus direct STA-MCA plus EMS, encephalomyosynangiosis, using a pterional approach. And there we number one saw that in adults the muscle takes only in 50%. Number two, by measuring quantitative CBF, the indirect, even the muscle with the big surface, had a insignificant contribution to the hemodynamics. So it was always the direct bypass. And this is why I argued when we discussed that I would rely on the direct. Here we are just flipping around the dura, which is not adding more invasiveness and more morbidity. It's not the EMS that we are performing. And in fact, we are studying it as in a way of a poor man's indirect, but we have also, we also know now that just flipping the dura around is not contributing significantly.
Thanks, Peter. I think for the sake of time, we'll keep moving. By the way, Peter, if you need to leave us because of the lateness, feel free. You know, we won't be offended. I know it's.
Well, I'm so excited by this panel, I will stay.
Okay, fantastic. Why don't you stop sharing your slides, but not your thoughts? And let's have David Langer show us his dazzling case.
We actually shut down our all of our surgery more or less the entire month of March and into April. I know I just teased Gary. My patients ended up in Stanford, and there was essentially no surgery here. But we were seeing a fair amount of hemorrhagic disease, and so when this case came in, it wasn't immediately clear that this even needed a bypass. But this was the patient's presentation. He presented with a dense left hemiparesis, arm worse than leg, and obvious chronic ischemic changes in the right hemisphere, along with this primarily thalamic hemorrhage. He also had IVH. I just chose these two, primarily to show probably where his deficit came from, as well as the CT that's showing some sort of chronic element to this. There's actually IVH as well. He's 57. He ended up having bilateral carotid occlusions with this. This is the vertebral oblique, and this is slightly oblique angiogram, left vertebral, and you can see the Moya-Moya-esque collaterals. I'd also like to point out, you can see the left PCOM on this AP view filling the left MCA, and in a significantly more robust way than the way the right MCA is filling. And I'll show you, additional views, but this is where the money was as far as this is all of his intracranial flow on an AP view. So you have a hemorrhagic patient. I'll show you the carotids just to keep you thinking. Thalamic bleed, IVH, and chronic right hemispheric ischemia. So this is the left common view, looks chronic on the left side. And this is the right common carotid artery with very paltry, you can see very delayed filling. If you can see my pointer on this, when I used I can't show, I don't have a pointer, but you can see the internal carotid on the right barely fills. Early, you can see a little string. You can see the ICA, that little portion of the internal carotid on the lateral view of filling from this little string, but very little, if any, ECIC collateral through the ophthalmic, essentially none. So he basically has a functional occlusion, despite there is maybe a small amount of flow getting through the right common carotid. And he was hemiparetic, but improving, was anti-gravity in the arm and leg, and developed an acute worsening. We were working him up. This was his MRI. You can see that this didn't all happen at this. You can see some volume loss of the right hemisphere, these chronic flare changes of the right hemisphere. You can see the focus of blood in the thalamus. You can see some left-sided changes as well, likely related to his left chronic occlusion, as well as the atrophy with an enlarged atrium in the right hemisphere, consistent with some chronic changes on the right side. We NOVA every patient. We go through our workup for Moya is NOVA SPECT. We have a terrific nuclear medicine group here.
David, explain to the audience. Some of them may not know what NOVA is. Just say a little bit what it is.
So NOVA is a quantitative MRA. It's a phase contrast MRA that's based on a time of flight image. On the left side is the time of flight MRA. And then from this image, we can select voxels in a three-dimensional space that are essentially parallel. The voxels chosen parallel to the identified artery, and then do a separate phase image. It takes about 15 seconds we do a separate phase images for the vessel of interest. This is Fatty Charbel's genius idea. He, you know, basically with his group at UIC, basically developed the math first, and then developed a company. Originally was called Canvas, then Vazol. Vazol still exists. The problem is it's a quantitative MRA, and there's the coding for this, and the value to radiology is minimal, and so they've had trouble keeping the company solvent. But to me, it's an essential ingredient when I work up MOYA cases, both pre and post-op, measuring my graft flows, measuring the recipients, knowing what I'm trying to replace as far as a volume, which really in this case had a big impact, because in this case with a small PCOM filling the left MCA, this patient had 177 cc's of flow in the left middle cerebral, which is above normal. The normal flows in the middle cerebral, I think, around 150. For a 50, 60-year-old male, the average MCA flows are around 130 to 150. So he had what I would consider a normal degree of MCA vascularization on the left, and his right was unmeasurable. You can see on this MRA in more of a sort of a axial view, you can see the small left PCOM coming off the left P1, filling that MCA, and there's no identifiable right middle cerebral artery. And he rapidly became pressure dependent. And the question was, is this a COVID issue? Is this the clot? You know, is the hemorrhage somehow causing this? Is this a flow problem? So I'd leave it up. I'll ask the panel at this point what you would do. He had a vastly neurological deficit with this workup thus far. So I thought I'd ask the group what your next step would be.
Ben, what would you recommend? You're muted. So with the no flow in the right MCA, the ICH in the right
And a
thalamus.
hemorrhage. So it's essentially a theoretic like a hemorrhagic, but now there's hemispheric hyperperfusion in the setting of COVID with a becoming pressure dependent. We actually keep his exam at its new baseline, because he came in, you know, actually mildly hemiparetic. He developed progressive hemiparesis, but was becoming pressure dependent. But we have really a hemorrhagic, you know, hemorrhage in the thalamus with this QMRA, quantitative MRA, showing no flow in the right middle cerebral, normal flow in the left middle cerebral, essentially poor peel collateral from, I don't even see the right PCA on here, which you can see a poor PCA flow. And so it's almost like an isolated right hemisphere, no obvious large distribution stroke of the right hemisphere. So what would be the next step? Would you continue to work the patient up? Would you operate? What would you do?
David, how long time ago this patient have hemorrhage?
5 days.
5 days.
Yes.
Oh, 5 days. For this kind of patient, I only do the indirect procedure. I have a question for Professor Steinberg. How long would you wait for the hemorrhage, for the direct bypass after the hemorrhage?
I would treat him medically, keep his pressure up, to perfuse him. I would not operate acutely. I would wait
Yes.
more than 5 days. I probably would try to wait, you know, several weeks if I could, because of the risk. If you absolutely can't get him out of the ICU, I might bite the bullet after, you know, 10 days or 2 weeks. But I think operating someone like this, he's had a hemorrhage, he's got ischemic brain. I think there are very, very high risks in doing any kind of surgery, even an indirect bypass.
Yes, normally I will wait for 3 months after the hemorrhage.
Yeah.
Yeah.
And he's COVID.
But if the hemorrhage is big and the big hematoma, you can remove the hematoma and do the indirect bypass at the same time.
Well, it's a
Indirect,
it's a thalamic clot. I don't know why you don't want to take this clot out.
No,
No, not for this one.
that's a tough case, David. What did you do?
Well, would you do
Did a
anything else?
bypass and saved his life?
Do any other workup? Anything else you'd add to the workup?
What did your perfusion study show?
So we did the Diamox SPECT first.
Yeah.
I didn't do the second stage of the SPECT. He was on pressors. That was the Diamox.
Right.
David, did you do cardiac echo?
All normal. Everything was normal.
But then he was COVID positive, right?
Yeah.
I mean,
But he wasn't symptomatic. He wasn't there were no, D-dimer was low. His procalcitonin was low. All of his serum indices were low, but he was COVID positive. It may have been, a few weeks before. This is a funky disease. I don't think we fully understand this disease on it. He didn't know pulmonary, no respiratory symptoms at all.
But these patients,
We're just testing everybody. Everybody got tested.
right? But they can get a vasculopathy or a vasculitis. They can get a hypercoagulable state.
I agree, but you know what? Here he had large vessel. I mean, again, I don't think it was a Moya case. I mean, he has large vessel occlusions. This is the left side. Just to reiterate, he had bilateral carotid occlusions. It's basically a extracranial occlusive disease, but he had this collateral that was Moya-Moya-esque. He had kind of this diaphanous collateral, likely led to the thalamic hemorrhage. But
yeah,
he's also having hemispheric hypoperfusion based on the MRA and the SPECT and he was pressor dependent.
Right. But we've had patients like this. When we did the cost study, we had patients like this, and sometimes if you write them out in the ICU, you think they're not going to develop collaterals. Their collaterals kick in after a week or 10 days, and you can get them out of the ICU. You can get them off pressors.
Well, I would agree with you, but look at his collateral. This is collateral. All of his intracranial flow is this. This is it. That's it. He was feeding.
Right, but I know you're going to tell us you bypassed him, and he did well. Is what you're going to tell us, I'm sure.
Perhaps.
But I think it's risky. I think for all comers that many of them will not have a good outcome with that. But if you're stuck, and if he were in the ICU for say a week or 10 days, and you're not getting anywhere, then I might bite the bullet and.
All right. Say you had a bilateral carotid occlusion patient that didn't bleed, that had that exam. What would you do?
And did he have a stroke?
Yeah, this guy had a stroke. I mean, he's had a stroke.
Right. If they have a stroke, I wait. I just think the risks are too high. His stroke
was the hemorrhage, though. He didn't have an ischemic stroke
yet. Right. But he's at risk.
He's developing it. Maybe he's developed progressive neurological deficits requiring pressors to keep his left side functional.
You're stuck. But, you put patients like this under anesthesia, their blood pressure bounces around. I think he's at risk for both ischemic problems and hemorrhagic.
But David, do you have the angiogram of the right side ICA?
Right. This is the right. There's no intracranial flow from the right. Just this little string.
No. The contrary to the ICA. I want to see the ACA, ACOM energy. ACOM.
This is it. There's no intracranial flow. This is the vertebrals. The only intracranial flow he has is this view. That's the right middle cerebral. You can see it filling from the right PCOM. That was a minimal filling from the right PCOM.
He has bilateral carotid occlusion.
Yeah, this is the right common. There's no flow intracranially from the right side. This little stump of the right ICA from that string on the right ICA. That was it.
What does the left carotid look like? The left intracranial.
That's the left carotid. The left carotid actually had ECIC through the ophthalmic.
But he's occluded. This is the left. Yeah, he's occluded bilaterally, right?
Yeah.
Remember the criticism we had of the COS is that it excluded patients like this. I mean, he's a hemorrhage, he's not a, that remember the mean time to randomization in the COS was 72 days. So you know that cases that were like this in ICU couldn't sit up without getting a TIA were excluded. So we don't have a randomized result to tell us what to do with cases like this. And
I think the problem
I'm aggressive with them.
The
But
problem for this for me is this isn't Moyamoya disease, number one. That's number one. It presented because of the nature of the collaterals. We also know, and this came from the Chinese literature, that if you have PCA collateral through the thalamus, they have a higher rate of hemorrhage.
Yes.
Right? So, but it wasn't Moya. This is his MCAs, the carotids are open. He's got extracranial occlusions, but his collateral was chronic, I assume. I mean, to have an angiogram that looks like this, you know, this is, but so he was so ischemic in the right hemisphere that he developed these kind of like Moyamoya-esque right-sided collaterals. He didn't have a bleed on the left side. It's right thalamus, that's where his collateral was. And so his hemorrhage was a Moyamoya type hemorrhage in a non-Moyamoya case. This is bilateral carotid occlusion. So the reason why this was difficult for me, I agree with you guys. You know, we were sort of combining, it's like we're combining the thoughts about when you intervene in Moyamoya versus carotid occlusion versus, you know, a progressive neurological deficit, pressure dependent, hemorrhage versus ischemia. It was one of the most interesting, you know, it combined almost all the difficulties that we have with bypass and ischemic bypass into one case. And I agree with you. I was flummoxed. I wasn't really sure what the right thing to do here was.
so what did you do, David?
This case.
So what did you do, David?
I bypassed them. I was uncomfortable with him. You know, he was on pressors. Every time we backed him off, he would get worse. He was up to 180 systolic. I was worried about bleeding again. You know, the other question is, we have a hemispheric hyperperfusion. I mean, when I got this SPECT, I was like, forget it. I mean, ANOVA helped me a lot here because I knew that his flows in the left, he needed 100 plus cc's of flow on the right side theoretically, even though he didn't have a large, you know, he doesn't have a huge stroke on the right. Most of his hemisphere is preserved. So even if you give him, you know, 20, 30% discount on flow on the right, he still needs a lot of flow to preserve that hemisphere. And I was concerned if he just had the hemorrhage and had an MCA that had really any kind of reasonable flow, I might have waited. But I thought he was at risk to lose his whole hemisphere. So I did a double barrel bypass. We did both the parietal and the frontal branch. You can see the donors here. Well, we both used both branches. I used the frontal branch on the temporal side. That means the parietal branch, the temporal side, was more of a, you know, posterior frontal, and the frontal, true frontal branch on the frontal side. And this was the result. And he actually stabilized and did relatively well. His exam improved gradually. He was in the hospital for another week and a half and went to rehab and did well. No hemorrhage. We controlled his blood pressure. I've used minocycline in these patients, whether that works or not. I run all these places on minocycline post-operatively. I haven't really seen a hyperperfusion hemorrhage recently in the last 5 years from a non-hemorrhagic MOYA. I haven't seen a hemorrhagic MOYA except delayed. I haven't seen one in the hospital. But I think that, you know, you might have gotten away with being conservative here, but I actually have a video of his exam on playback, you know, where I'm using this mobile application to my team sends me videos of these patients every morning. If you want to see that, I just don't have his name uncovered. I think it'd be hard to show it to this audience, but I have a whole video, all the videos of his exam along the way. And I think this was, at least for this particular case, the right answer. At least for now, he's doing well, relatively well.
I think it's a very important case. I know it's complicated, but I'm glad you showed this to the audience, that there is a role for quote-unquote urgent bypasses, although I agree with Gary, certainly those people, similar to the SUNT criteria of, you know, with carotid endarterectomy of higher risk grades, but certainly can save the day on the right patient, well chosen. Thanks, David. Can you unshare your slides, David? Gustavo, can I invite you to share your slides, please? Gustavo Pradilla.
Art sharing here.
Okay. And thanks for joining us.
Okay, excellent. Well, that was a great case, David. And again, thank you, Dr. Morcos, and my beloved Miami family for allowing me the opportunity to be here with some of my heroes in vascular neurosurgery. I keep learning from Dr. Morcos many years after fellowship, it's lesson after lesson, and I'm quite grateful. So in the same line of David's presentation, I just wanted to share a slightly different case and get your thoughts about this. So this is a 22-year-old African-American woman that presents with sickle cell anemia and a seizure disorder. She was first identified to have issues around age 2, and she was treated conservatively and monitored through different means. And for the past 16 years or so was on chronic simple transfusions, and they were watching her with TCDs, and her velocities seemed to have stabilized with that type of therapy over time. In 2017, when she was 19, she has her first major vaso-occlusive pain crisis with some chest pain. And shortly after that, then she presents with her first TIA, a 5-minute event. This was her MRI with diffusion on the left at the time. So not anything major was identified there, but on her MRA, as you can see on the left side, she's starting to have some carotid bifurcation, proximal M1 bilateral disease, worse on the right than on the left side. So she starts to go down the traditional pathway, and this is her angiogram at that time. On the right side, there's a little bit of filling defects centrally. You can appreciate the same on the lateral view. And on this right, slightly oblique view, you can see a very slight beginning of some collateral vessel formation in a moya-moya pattern on the right side. So following this event, she's completely back to normal, essentially asymptomatic. This is her left carotid injection, again at the time. So some very minor changes, but overall consistent with stage 1 disease. And one of my interests in presenting this case is that in Atlanta, we have a large African-American population, and the incidence of sickle cell traits and sickle cell disease is quite high, and we have a large sickle cell center. And these patients periodically come up, and we're seeing a rise in the cases of moya-moya presentation in this very specific patient population. This was her external circulation, so she had suitable bilateral donors for revascularization. Because she was so asymptomatic and her family was a bit hesitant, she was managed conservatively at first. We did an exchange transfusion. She got from 74% of her hemoglobin S down to 33%. We typically treat these patients with a goal of less than 30% of their hemoglobin S, and she was doing okay. And follow up, and then a few months later, about 6 months later, she presents with another episode here, and now she has a significant hit on the right side that you can see there in the diffusion. Her MRA shows more progression of disease, so the changes are more profound bilaterally, again, more pronounced towards the right side. And we get her admitted. She gets another exchange transfusion, and she does okay. Her symptoms, thankfully, pretty much resolved again. And we are discussing with her family to do a revascularization procedure. She's not hesitant. kids have a lot of issues with their pain crisis. They come in and out of emergency rooms so frequently that they are not the easiest people to get into surgery. But she presents again a few months later with another event, and this time is more on the watershed distribution. You can see these very small changes superficially here, and on her CT angiogram, again, those changes around the bilateral M1 distribution with progression of disease. So she's becoming more and more symptomatic. We just add a little bit more hydroxyurea to her regimen and aspirin, still trying to talk her into surgery, and she's still kind of refusing. We finally talk her into it after she presents with another event. We get now, this is about 9 months from her first presentation, so we get another angiogram. She has dramatically progressed over these few months, and it's not perhaps something that you see with such rapid progression in traditional non-sickle moyamoya, but it seems to me that this pattern of more rapid progression tends to be more common in these patients with sickle cell. This was her left repeat, also some progression, not as severe as in the other side. And so at this point, the first question is, since there's a rapid progression of symptoms, is this someone that you would revascularize sooner and really push hard to get them into early revascularization versus progressing with this medical management and exchange transfusions that maybe buy you a little bit of time, but are not really providing a more definitive decision? So we did revascularize her eventually and on the right side, and she did quite well. About 6 months after her right-sided revascularization, she presented with left-sided symptoms. And you can see she had some distal MCA changes there. So we treated her with left-sided revascularization, and eventually she did well, and she continues to do well about 1.5 years later. This was her 1 month follow-up MRI. She had a fluid collection that we were watching that thankfully was asymptomatic. So we looked at a few studies. There's really not a lot of literature to draw from for sickle cell patients with moyamoya. We looked at 6 studies with about 120 patients. And again, a lot of people, a lot of neurologists manage these patients just with transfusion. So on that series of patients, 73% or 73 patients out of those 122 were treated surgically. And what we found was the rate of stroke for the patients that were treated surgically was excellent. It was 1 perioperative stroke and 4 postoperative strokes. And if you look at the medical complications with transfusion alone, 47% of those patients had ischemic complications. So it is weak evidence, obviously retrospective, but it's a hint that the principles of moyamoya treatment can be applied safely to these patients with sickle cell. So for our distinguished panel, I'd love to know your thoughts about patient selection in this specific population versus non-sickle cell disease patients. What would you do differently, and what do you do differently with your protocol preoperatively and postoperatively? I learned from Dr. Morcos to be very vigilant preoperatively. We hydrate our patients in the induction room before they undergo anesthesia. We watch them very closely during induction. We use full dose of antiplatelets that we start several days before surgery. And we watch them in the ICU, like Dr. Steinberg mentioned. We try to maintain their blood pressure goals elevated for at least 48 hours. What we were sort of flying blindly on was we revascularized the right hemisphere, which was the most symptomatic, but what was the right timing to revascularize the left hemisphere? Should we maybe have done that in a more proactive way earlier?
Gary, why can you tackle the question of, thank you, Gustavo, question of timing? Just address some of those. That's the most important issue that came out of this, the timing.
So Gustavo, I would have done exactly what you did. I would have bypassed the right side. I put all my Moya patients on aspirin. I want them on, which is unusual because there's no other condition where we operate on aspirin, right? We're nervous to put in an EVD on aspirin even. So, but I think it's very important. I know the Japanese don't always do that. I would not have revascularized the left side immediately. I would have waited at least a month for the left side, but I would have revascularized that. And the question is, in the face of the acute stroke, I probably would have waited at least a week after the DWI positive stroke before operating, because I like to, you know, as I say, I think your complication rate in general is higher if you operate in the face of an acute stroke. If you could wait even longer than a week, you know, if she's unstable, I'd probably wait a week. But I think you did the right thing. And the other thing, Gustavo, is Mike Scott and Ed Smith at Boston Children's Hospital wrote a nice paper on sickle cell and moya years back. And they also concluded that there is a definite benefit to doing bypasses on sickle cell who have moya in addition to the transfusions, and patients do well. So whether it's two separate diseases or whether the sickle cell actually predisposes or causes the moya is not clear, but I think these patients should be bypassed actually sooner rather than later, if you know.
So Gary, so let's say you do one side and the other side has some angiographic disease, but the blood flow is not, you know, the reserve is not diminished. Is there a role for quote unquote prophylactic bypass of the other side? Will the bypass even survive if it's not needed? Well, that's what I'd like you to address, the timing of doing another side.
So if I mean, that was, when patients progress like that, I bypass them because, you know, when they progress that quickly, as long as they have a, you know, a moderate or severe stenosis on the other side, even if they don't have impaired hemodynamic reserve, I bypass them. You know, the Boston group does bilateral bypasses on everyone, even if they're asymptomatic. Another thing you can look for is an IV sign. If there's on the flare, if there's enhancement, leptomeningeal enhancement called the IV sign, that's an indication that there's slow flow and that they have decreased blood flow. So
yeah, 50% of those IV sign patients will become symptomatic within very few years.
So I'm more aggressive with you know, sickle cell if they've got moya. I mean, I don't bypass them if they have normal arteries, but.
Ben, how do you handle some of these issues? I don't know what percentage of your patients have sickle cell. I would assume very low, correct? Or
yes, very low. I only have 3 cases of this sickle cell.
You're not
all. They are all pediatric patients, so I only do the EDMS for them. The result is quite good.
How about maybe slightly different question than Gustavo was asking you? Then talk about the contralateral bypass after you've done one side in a non-sickle cell patient. The timing of it. When would you do that? In regular moya.
Yeah, and normally after the TIA, the first time TIA. Yeah.
So you do not bypass an asymptomatic contralateral side.
Yes,
you know
just a follow-up. Yes.
You
I have a question for Steinberg. So you did a lot of DIMOX challenge test because, you know, in China we don't have the IV DIMOX, so we don't have any experience on this DIMOX challenge test. So is there any potential risk for this kind of patient because the patient already got some ischemic?
Yeah, that's a great question. We get asked it because, I mean, the idea of the DIMOX is to stress the system. We've had, so as I've shown you, we've got almost 800 patients that we've treated, and almost all of them get DIMOX. We've had a few who have TIAs. I have never seen a stroke from Diamox.
Okay. So it's very short time.
Yeah.
Okay.
I would
Gustavo,
agree. I've never seen a stroke from Diamox either, ever.
Okay. Okay. Great.
Gustavo, any other questions you want them answered?
No, the other question was what is their pre-op protocol? You know, is there anything they want to do in particular? Hydration, blood pressure goals, antiplatelets. I think some of that was answered. And the other one was follow-up imaging. If you have someone who is revascularized on one side, has angiographic changes on the contralateral side, and not showing clinical symptoms, do you want to image these people and catch them when they start having maybe perfusion deficits on challenging before they have a symptom, or do you wait and just image them when they become symptomatic?
So I can address that. I think you did the right thing. Hydration. Sometimes we'll even put them on Florinef to increase their intravascular volume and keep the fluids in. We push the map up. We put them on Midodrine. If they're outpatients, if they're severe, we put them in the unit and put them on drips. And antiplatelet agents, absolutely. So all of that. And then we follow them, assuming they're not symptomatic, with non-invasive studies once a year, an MRA usually, or a CTA, but that uses radiation. So we follow all of our unilateral patients with non-invasive imaging. And once we bypass them, as I say, at 6 months, 3 years, 10 years, 20 years, and now we're coming up to 30 years, we do an angiogram and another MR scan with Diamox. But we do follow them annually, and if we see progression, even without symptoms, then I will bypass them. If we see significant progression to a severe stenosis, I'll bypass them prophylactically.
Okay, thank you, Gustavo. Did we lose Matteo? Matteo, are you with us? Ignacio, do you see Matteo, our fourth panelist, or did we lose him?
I think we lost him, doctor. I don't see him.
Yeah, okay. Let me move on to some of the audience questions now. Let me start with a question actually from my colleague, stroke neurologist, Negar Asdagi. Negar, thanks for joining our panel. So I'm gonna read her question. Most perfusion imaging post-processing software measure CBF as a relative measure, meaning relative CBF, and not absolute CBF. Hence, this is relative to the perfusion parameters of the contralateral side. Can you please comment on how quantitative CBF is calculated at your institution? How does Tmax measurements factor in your decision? And do you use a cutoff? Gary, I don't know if you got the whole question. Yeah.
Yeah. So for a while we were doing SPEC studies, Xenon CT, and NOVA on all of our patients with and without Diamox. We don't like SPEC for the reason that was mentioned by the questioner, and that is it's relative and it's not quantitative. So we abandoned SPEC. We are very MR driven here. So we use MR, and we do take Tmax into account. We do not use cutoffs because it's not relevant. Like for an acute stroke, we have cutoffs that have been shown to be beneficial in terms of making a decision of who to revascularize, usually with mechanical thrombectomy or TPA, but we don't use absolute cutoffs. And I actually think the hemodynamic reserve is much more important than the absolute blood flows, because your Tmax is always going to be delayed when you have an occlusion, but they may have enough flow from collaterals, but the impaired hemodynamic reserve or steal, I think, is a much more important phenomena. But again, we do not use absolute cutoffs for Moya-Moya.
Ben, do you want to address the same question? What do you use at your institution for CBF?
Yes, we use ASL of MRI, the ASL sequence, and the SPECT we use a lot, and the CT perfusion can give you the parameters of Tmax and the blood flow, and the CBV, CBF, and the TTP. So we use this. Actually, we also do the angiogram by ourselves for the patient directly. So we will also analyze the pressure gradients, just like I introduced in the slides. Okay. So this is very important in planning for the direct bypass.
Question from Dr. Kasinathan. Does the difference in caliber of the vessel affect patency of the graft? If so, how do you match them? Ben, do you want to take this first? Caliber of the vessel. Does it affect patency?
Actually, the caliber is means some potential carrying capacity of the donor artery means, and but the most important is delta P, I think, for the direct bypass. So if the delta P is very small, the caliber is big. Actually, the blood volume is also very small. So delta P is if you choose the right position, and the delta P is quite large. So this kind of bypass the blood flow can increase a lot after 1 or 2 weeks. Normally we use NOVA to measure the blood flow. For the single bypass, just as Gary mentioned, around intraoperatively, normally the STMCA bypass for MOYAMOYA is around 20 to 40 millimeter per minute. But after 1 week, 1 or 2 weeks, it may increase to 70 to 80 millimeter per minute. And for double bypass, even can beyond 100 millimeter per minute.
Okay, thanks. Gary, this is for you. Dr. Mohammed Helmi from Egypt. He'd like to ask you, what was the most common neurological deficit that you observed in some of those slides you were discussing complications? Was it aphasia, motor deficit, or sensory disturbance?
Great question. So for the transient neurologic deficits that resolve and they're not strokes, most common is expressive aphasia. And I think it's because there's a very large representation of the orobulbar musculature. If you remember the homunculus, the tongue and the mouth, and it's so it's not always an aphasia. As I was saying, I was trying to suggest it's more of an orobulbar apraxia in many cases, because they can write. It's interesting, they can write, but they can't talk. And when it gets severe, they can't move their tongue. Sometimes they can't swallow. I've had patients who can't open their mouth even, and then 3 days later it's resolved. Second to the left, and sometimes it's receptive aphasia also, and it's almost always in the left hemisphere. After that, it can be a motor or sensory deficit, but that's much less common.
Okay. And to the speakers or the panelists, from Dr. Michael Rallo, how do you handle a pregnant woman with MOYAMOYA? I assume obviously symptomatic. Any experience with doing bypasses during pregnancy? I've certainly done it. Gary or Ben?
Yeah, I don't like operating, unless it's necessary. So I will usually try to get the patient through the pregnancy. If they've had a TAA or a minor stroke, we'll put them on hypertensive agents, midodrine and Flurinef if necessary, hydrate them and see if we can get them through the pregnancy. If they're really unstable, which is pretty rare. Usually you can get them through medically. I would operate. We just published a paper on moya-moya and pregnancy, and we showed that patients with moya-moya who we bypassed prior to pregnancy, none of them had a stroke in the while they were pregnant or in the in the post-pregnancy period. I think we had one TIA, and we compared that to patients who had not been bypassed, and a number of those patients had strokes during pregnancy. So we believe much better if patients are symptomatic to bypass them before pregnancy. But it's pretty rare that I see a patient who we can't get through pregnancy, you know, with medical therapy, and then after they deliver, we'll bypass them, you know, within a month.
Great. Ben, one of the audience member did not quite understand your Chinese roll technique. Can you just re-explain it briefly, what you're doing?
For the pregnant?
No, sorry. The Chinese spring roll technique you gave in your presentation when you wanted to save the middle meningeal artery. They didn't quite understand.
Okay, it's a Chinese spring roll.
Yeah.
Yeah, it's a Chinese spring roll is a kind of food. Yeah.
Yeah, I know that. But explain what you're doing.
Yeah. So it's just I mentioned, like actually the MMV was very hard to get hemostasis by coagulation, and at the same time you couldn't. May I share my screen?
Yes, sure. Go ahead.
Okay.
Essentially, he's doing this to avoid coagulating the artery by tamponading the vessels.
Yes. Can you see the screen?
Yes.
Okay. So you can see this is a horse on MMV. Actually, this is a kind. MMV, it's like a kind of sinus. So it's impossible to coagulate at the same time to keep the integrity of the middle meningeal artery. The middle meningeal artery was going inside of the MMV. So the only way is to protect the MMA at the meantime to getting the hemostasis of the MMV. So I use this technique. I use a gel foam strip and to make like a barrel.
Yeah.
Yeah.
Thank you. A question from Dr. Jayanand Sudhir. I have encountered extreme fluctuations in blood pressure intraoperatively for 2 patients. Both suffered contralateral hemispheric infarction. Would like to know from the panel if they had a similar experience and what was your response or your strategy. So
can you repeat the question?
Severe fluctuations of blood pressure intra-op resulting in 2 cases in this in Dr. Sudhir's experience, contralateral infarcts. How can we prevent it? What's your advice? How do we respond to that? I mean, I guess talking to our anesthesiologist and showing.
I honestly think that that's when you have bilateral, that's the scariest patient. It's the contralateral. I mean, ipsilateral, we know what to do, but when I have if I have bilateral case, that's when I really jack up the concern from anesthesia, no mannitol, blood pressure control. Because when you have the strokes, more often than not, it's going to be in the contralateral side if you have a blood pressure problem. And that's communication. It's make sure the anesthesiologist knows what the problem is, talk to them the night before, go over the case with them. A lot of times they find out about the case the morning of, they're not prepared. No one spoke about it. It's this typical Moya-Moya case, whatever. And you have to be very vigilant to that. That really comes down to a team and the communication ahead of time and during to make sure everyone's on the same page.
Great. Dr. Pilonietta, do you use the 3:1 ratio of the diameter of the stoma vessel to diminish the risk of occlusion of the vessel? Ben, let me ask you to maybe to answer this. What do you have any? What's your advice on the ratio of, I guess, donor to recipient, or what, just mathematically or geometrically? What's, I know you covered it, but we rushed you through those slides. Tell him your approach to the geometry of how you construct your.
Yes, if the ratio is achieved 3:1, actually I will quit the direct bypass because according to the Poiseuille's law, the blood volume of the donor and the recipient artery has maybe 80 times difference. So this is.
Ben, how about, I've done this a couple of times. My colleague Mustafa Bashkaya also published. How about tapering the donor if it's too big, tapering it with sutures?
Yes.
Right.
Sometimes we can make it smaller, and use the smaller branch.
Exactly.
Yeah, you can always find some small branch.
Okay. Question by Dr. Gianluca Grimaud. Have you ever seen retrograde thrombosis after STA MCA bypass? I'm not sure what the question refers to, retrograde thrombosis I'm not sure if it's referred to the STA or the ECA, but anyway, if any of you wants to take this question, if you think you know what is meant. Retrograde thrombosis. Not sure. Anybody?
I thought he was referring to thrombosis proximal to the anastomotic site. That's how
you mean of the donor?
Right.
Yes.
Yes. So the recipient thrombosing just proximal to where you're anastomosing to, because of.
Oh, yeah. Any comment on that? I'm not sure. I've seen that specifically.
You know, we looked at our long-term patency rate, and it's in the high 90s. So it's pretty rare if you get a good bypass that it thromboses back. As I mentioned before, we talked about sometimes the angiogram shows the artery is widely open, but it's developed a lot of indirect collaterals, and you see more indirect than the direct, even though you did a direct graft. But no, I haven't seen that happen.
Okay, last question from Dr. Okba Gelab. Would like to tell Dr. Ben Shu that he's not operating enough. You need to do more cases, Ben, to improve your experience. I actually twisted the question to poke fun at you, but that's an amazing experience.
I had a question for Ben. You've done 7,000 bypasses for Moya-Moya. How many of those are direct?
Not totally, not all Moya-Moya.
Okay.
For all kind of bypass.
How many for Moya-Moya?
It's around 95%.
Oh, it's only 95% of those. So what's left? Okay. And are those mostly direct?
Yes. This is all direct. I didn't include the number.
Right.
Didn't include the indirect ones.
I see. That's a lot. I thought we had as I'm approaching 2,000, I thought we had a lot, but I'm very humbled by your experience. So
No. You are my hero. You know, you have much longer time.
Yeah, that means I'm a lot older.
Well, guys and ladies, it's 7:20. Any other questions, panelists to speakers? Any last minute questions before I let everybody go?
I just wanted to thank you, Jacques, for organizing it. I thought it was a terrific session. I always learn from these kind of sessions, and I was quite impressed. We had over 300 people,
That's not
participating.
counting the people watching us on Neurosurgery TV. I will get those numbers tomorrow.
Yeah, no, you've done a great job with this webinar series. So we're going to have to develop something like that out here to compete with you.
No problem. Let's make sure it's not on the same day, though. Guys, thank you to all of you, the audience. Have a great evening, a good morning. Bye-bye.